correctly. And she's I know Lyduine from conferences. She's a quite big name in the neuroimaging field in Alzheimer's, especially when thinking about amyloid-PET. And she's an assistant professor at the Department of Radiology and Nuclear Medicine at the Amsterdam University Medical Center. And yeah, thanks for being here, and thanks for skills.
Yeah. Well, thanks so much for the invite. Lovely to always be back in Madrid, although I was already saying I was hoping for slightly better weather compared to the Netherlands. Shockingly the same. So, oh well, but better food. So that's something. Yeah, so welcome everyone. I'm here to present for you on Amyloid-PET, and I made the title "A Picture Says 1,000 Words," because I think amyloid, as so many of our imaging techniques, is reduced to very simple information, which is clinically key, but there's so much more we can get from these scans. And I hope today to illustrate a bit to you guys and to discuss maybe a little bit further afterwards as well. Okay, so the official stuff first. These are my disclosures. So we have had that as well. And this is an example I always like to start with, just to have a bit of an idea what kind of audience I have in front of me, but also to provoke the question that I basically want to answer in this talk. So, to you guys, which scan shows abnormal uptake or is amyloid positive? The scan on the left, the scan on the right, both of them, none of them. Who thinks the scan on the left? Who thinks the scan on the right? Who thinks both? Who thinks none? I have no idea. So the answer actually is both are positive. What I want to illustrate with this example is that with the classic visual assessments of an amyloid-PET image, these two cases are considered the same. Amyloid positive, done. That's the end of the story. But as you can already appreciate, there's definitely differences between these two cases. The scan on the right has more amyloid pathology than the one on the left. This one on the left has particularly in the frontal lobe uptake, while the scan on the right also has something in the posterior part of the brain. So there's much more information that we're basically discarding when we're doing a simple visual assessment. So today I want to show you three main topics of what we can get from these scans that might have clinical utility: extent, spatial patterns, and something quite novel, asymmetry. Let's start with extent. So I mentioned before, the classic, what we use in our clinic is the visual read, where here's an example for flutamate, courtesy of GE Healthcare, with a negative scan on the left, where you always have high uptake in the white matter, but no uptake in the gray matter on the outside of the scan. And on the right, you can see a positive scan with high uptake also in the gray matter. And in general, if any region on one hemisphere is considered to be abnormal, you have a positive PET scan. That is the criteria. Sorry. But quantification can give us much more information on the extent of pathology than, of course, this binary assessment with visual read. And using quantification to support visual read really became a thing, I would say, with these hallmark papers, where they showed if you compare quantification to visual assessment, there's a very high agreement. Here are examples for flutamate, for beta-ben, in cognitively impaired, so more advanced clinical cases. So this was sort of the first hallmark paper to show, okay, there's very high agreement, so we can use quantification to support our assessments and hopefully also to look at extent. But of course, it's not a perfect world. If we're now moving earlier and earlier in our clinic, we see more difficult cases, the agreement between visual read and quantification came a little bit off. So this work by myself, published in Alzheimer's and Dementia, and you can appreciate in the red and blue, there's not a perfect segregation of the two groups. Similar was shown for flutamate in this large study, and also by the IDEA study with beta-P, that there's significant overlap between the two groups. So something had to be done, that we can use quantification in our clinical routine and actually maybe get information on the extent of pathology. And for that, the Centroid framework was brought forward in 2015 by Bill Klunk. So what Centroid basically allows us to do is if we quantify a PET scan, it can give us information that is comparable between sites, between tracers, and between scanners. So if we do a scan here, for example, with flutamate, and an SUVR value of 1.4 comes out, that value says nothing for a different scanner, a different tracer in Amsterdam. That is not comparable. Of course, we know it's probably positive, it's high, but it doesn't give an indication of how much pathology there actually is there. To allow people to communicate to each other and to come with cut points that actually has clinical meaningfulness, we need a common scale. And that's what Centroid provides us. So by anchoring our quantification into a group of amyloid negative cases, where the value is 0, and a group of individuals that have mild to moderate dementia due to Alzheimer's, where the value is 100, we can now say, okay, this scan has 30 centiloids, and that 30 means the same between here and Madrid, in Amsterdam, and in the States. And we know what we're talking about. Importantly, even though it is anchored in the 0 and the 100s, it's not the extent of the scale. So you can have values below 0 and above 100. I've seen scans with up to 200 centiloid. Also, if you open it, it's like booming positive, like it's obvious. But it is possible, just to keep that in mind. And this is basically what it does. So just to illustrate here, so you see the more standard quantification metric as VVR. You can appreciate there's different spread between tracers. There's not alignment in the groups. And after conversion, all of a sudden, these values become comparable. So with the arrival of Sentinel, we now had a marker that could maybe help us to actually standardize extent of pathology. And because it seemed to work so well, it became more and more popular in the literature. This is already almost outdated, I would say. I wrote this review 2 years ago, at the end of 2024 was published. But you can appreciate the peak of how much more Sentinel is being used in the literature. And it's also because most of the Alzheimer trials were using it as either inclusion criteria or an outcome measure. So these two things combined made the consortium I was part of really interested to see, okay, is Centiloid actually as good as it claims it is? And can we use it for measuring extent and supporting our clinics? So we've done a lot of different things, but one key paper I want to highlight is this one from my colleague Manaz from the BBRC in Barcelona. And she compared 32 different pipelines where she looked at different settings in which space she was looking in, so native space or standard space, different reference regions for quantification, you name it, different atlases. And basically, whatever you did to Centiloid, as long as you do the steps correctly, it is robust. So this gave us a lot of support that Centiloid is indeed a quantitative measure that can give us information on extent. One important thing came out though, for anyone who's ever going to use Amyloid-PET in the clinic, do not use PONS as the reference region. Some companies have this as their standard, but because of the data set you use to anchor your own data with, has a few individuals with lesions in the PONS, we think this introduces the bias that we saw for the PONS. So it's more dispersion basically if you use this as a reference region. So the suggestion is use the whole cerebellum, states that it's the most stable. Yeah, so this is the work that came from that one. All right, so now we had a metric that was introduced that claims to be a measure of extent with a nomenclature like standardized across different traces, cohorts that we can speak to each other. We've shown it's robust, tick. Okay, but what are now the cut points that we can identify that actually could help us to stage or individuals or support a visual assessment? And for that, I did, together with my colleague, a review of the literature. And basically, we characterized the literature that we found into 2 different sections. I won't show you all of it. I'll show you the overview paper in a second. But what we did as a first step is persistent pathology, the gold standard in our field. And what we saw is that the initiation of amyloid pathology was identified at 12 centiloids. So basically, if there was 12 centiloids, then someone had initial amyloid pathology. Below that, there was none. With a different staging approach for postmortem, a very similar value was identified. And in addition, they also observed that more moderate amyloid pathology was associated with a cut point of nearly 24 centiloids. And a different paper in different cohorts found a cut point for about 10. So these are a few highlighted, there were more out there, but taking this literature together, we concluded in our consortium that amyloid pathology can be reliably excluded below 10 centiloids. So meaning if you have an individual and that individual has a centiloid value for quantification below 10, you can be really, really certain that that person does not have any amyloid in the brain. Yes. Oof. Yeah, these were the postmortem studies by Lajoie. And I think they were also quite stringent with the follow-up time. I would say max 8 hours, which is quite standard in the field. I know you guys are a bit better, but yes. That was about max 2 years, I think. Yeah, if I remember correctly. It's been a while I read the papers in detail. Yeah. All right, so based on the literature we found, we say below 10, we know for certain someone does not have amyloid in the brain. What about the other side of the scale? So we had centroid versus clinical references. In this case, we had CSF and visual read. So our visual read comes back again. And interestingly, so the lower cut point compared to CSF, completely different data sets, different approach, also found 12 centroids. So a very similar cut point actually compared to pathology. So the stability of this measure seems to be very high, while the higher cut point was 30 centroids, so a little bit higher than previously identified 24. Compared to visual read, honestly, the literature went a bit more all over the place because we saw it was very dependent on what code was included and also the experience of the readers, how well they were able to identify someone with just a little bit pathology. So this was, for example, a study that had very little individuals in the mid-range, so the cut point was a bit higher. But I also have worked with readers that are very experienced, for example, in a very early population, and that cut point of 17 centroid was identified. For the large idea study, where we talk about thousands of individuals, it was the 24 came out. And in my own work, and in other cohorts from Amsterdam, we found 21. So again, these are a snapshot of the number of studies that we found. But collecting all of these together, we decided that 30 centroid is a conservative threshold above which you can be certain someone has amyloid pathology. And we did it conservatively on purpose because this was in the context of starting treatment. So you want to be very certain, of course, at an individual level that someone actually has amyloid in the brain before you can give them an anti-amyloid drug. So importantly, if someone has a visually positive scan, but maybe a centroid below 30, does not mean the scan is not positive. This is just to support and to especially support readers that are maybe less experienced and to have high certainty. All right, so why did I give you this context? So within the consortium that I worked in, we put all this information together to come to these rules and actually presented all this work to the European Medicine Agency, showing that we can use quantification in our clinical routine to support our visual read. So the two rules that we came up with were these two, a few more in a second, as I showed. And here's the overview paper that we presented. And the EMA actually approved the use of centroids for support in our clinic in June 2024. And actually very recently in June 2025, the FDA has also adapted our work for quantification to use in the States. So here's a summary of the scale that everyone's always interested in. So the 10 and 30 indicating we have these two cut points. But of course, everyone's now thinking 10 and 30, what do you do if you fall in between? What happens then? So this is this gray zone that's often suggested to be like, we're not really sure what's happening. There's a lot of studies ongoing or have already been done when there's a high risk for someone actually to develop more amyloid pathology. I think more needs to be done there. But in general, the closer you get to that 30 cut point, there's higher risk of actually developing amyloid longitudinally, or that we see people having clinical decline over time. So more work needs to be done, but it shows that there's a sliding window in a way. If you're interested in the paper, you can scan the QR code to see the full overview of all the data that we looked at. Okay. So using now this context of 10 and 30, we want to see, okay, does it actually benefit readers? Will it now help us to improve our visual read? And for this, we used the data from the consortium I was part of, Amyloid-PET, and this was from the diagnostic and patient management study. So these are from patients that came to our clinics across Europe. You can see the partners here, and had either SED, MCI, or dementia. From this cohort, over 800 individuals, we selected the ones that were the most challenging cases, where it's always been argued that probably quantification will be the most useful in those. And these were selected on the local reader either had a low confidence read, so they weren't sure, or there was a discordance between centroid and quantification. So 85 cases were selected, and we had a few like clear-cut negative and positive cases to balance out the dataset. And they had 5 readers. And all of the readers assessed the scan before the quantification, then they got the centroid results, and then again, they did the read again to see what happened basically to the reads. And what we saw is that post-disclosure of centroids, the quantification was considered to be useful, and 75% of the reads, so quite a high number of these challenging cases, don't think of all scans that we do. There was an increase in reader confidence, so the confidence of the readers increased on a Likert scale. And there was also improved agreement between the readers. And reaching a kappa of 0.74 in such a difficult subset is quite impressive, actually. Most of these studies turn out way lower. But, as I said at the beginning, it's not a perfect world. If you look at these Sankey plots, we can appreciate that there's a few weird cases in here. So, for example, we have here the block of scans where all readers were visually positive, are very certain about their assessments. And this individual actually has a very low centroid, but the reader stuck to the guns and said, no, it's a positive scan. So we were very curious to see what's happening to that particular image, that, you know, such a discordance, and still the readers were very certain. And so a few other ones, for example, a negative read and then a positive centroid. So we looked into a few cases. This is the first case I wanted to show to you. Pre-disclosure, 3 of the 5 readers considered this scan to be positive, but with a lower confidence. And the centroid was 42, so positive, way above the 30, high certainty. Post-read, all of a sudden, now all readers said, okay, it's indeed a positive scan, and the confidence went up. So this is an example of a case where there was a movement in the scan, the quality was a bit lower, and qualification helped with the readers that weren't sure what was going on. Now the more interesting one, an atypical uptake. So this was a scan that was considered to be negative by all the readers, with a low confidence though. And the centroid is indeed low. So you're like, oh, perfect agreement, perfect. And indeed, the readers remained negative, confidence went way up, but for those that are maybe a bit more experienced, you can appreciate there's actually some uptake in the scan in the posterior part of the brain, particularly in the occipital lobe. Occipital is not part of the reader guidelines, so you can't make a scan positive based on occipital, except for Fluebetapir, but not for Fluebetaben and Flutemetamol. So officially, you can't make the scan positive. Occipital is also not captured in the centroid mask, so what the centroid region looks at. So it's fully in agreement, it's correct, but there is actually some uptake. So what's happening with that scan? I'll come back to that later. And finally, that weird case. So all positive at baseline, good confidence, but the centroid was 5. What happened here? So this is another example of atypical uptake. And in this case, not only the occipital lobe was involved, but also temporal. And because temporal is involved, you're allowed to make the scan positive visually. But this region of the temporal is not captured a lot in the centroid mask, so the centroid quantification does not go high up enough to be captured basically in the value. No, luckily the reader stuck to their guns and the confidence was basically the same. But this is a very good example of how quantification and visual read should always go in conjunction and never one or the other when we're making clinical decisions. For research, of course, it's a different story, but for clinical decisions. So taking that, as said, in conjunction, and in case of discordance, be aware of the quality of the image, lesions that can maybe affect the quantification, and the focal uptake. So together with the rule of 10 and 30, and these 2 main points, these are the documentation that the EMA has approved for use in Europe, and now the FDA also for in the States. But we have more on this scale than 10 and 30. What about this half that we're just completely ignoring, basically? Everyone's always interested to identify positivity and positivity with high certainty. But I here want to show you, of course, the potential of extent. So looking beyond yes, no, but actually how much someone has. So this is a field that really needs to do much more work still, but there are some interesting indications that the amount of pathology might be a risk factor. For example, it has been shown that if you're below 50 centiloid, the risk of having tau pathology beyond the medial temporal lobe is very low. Very different approach, and it's a little bit more liberal, but basically cut point for 36 was identified. So basically you have 10 to be sure someone does not have anything, you have 30 to be sure someone has amyloid, and if you're above that, there's an increasing risk in developing tau. And for those that are familiar with the donanemab trial, where they actually use the amount of tau someone has in addition to amyloid positivity for the drug, their cut point between the intermediate and high group fell at 60 centiloid. So these things together illustrate that beyond the binary classification of positive or negative, the extent of pathology might have information on someone's potential benefit of drugs. Do you falling in this category where they saw more clinical utility, or are you falling in this category where the chance of clinical utility is lower? Again, much more work needs to be done here, but I think there's great potential. All right, so we covered extent. But I already showed, of course, a bit of the spatial patterns. Not everyone behaves according to the same way. Back to that case that I showed. Positive by the readers, very low centiloid, but still positive. The majority of amyloid pathology in cases start in the orbitofrontal and in the precuneus. So basically, if you look at the sagittal image of the brain and it's positive, you're done. And if it's negative, there's a very good chance the rest of the scan is also negative. But there are scans that have a very different pattern. What does that mean? Why does these people deviate from the mean? Does it have any utility? So for a very long time, we had a one trajectory assumption, as Michel very well knows, where we looked into assuming, like, really trying to stage individuals on which region becomes abnormal first and subsequently blah, blah, blah. This was actually not a very new idea. I mean, it's something the pathology has done for many, many years. Only they tend to use the whole cortex as one stage, which is where most of the variation we were looking at falls in. So imaging helped. We had different models that came out, increasing complexity. And there was already shown if you indeed measures the extent, you can improve the risk prediction basically of individuals. So if they have more, there's a higher chance of conversion and these sort of things. This was my own work from back in the day. But now we want to go one step beyond, having regional information in there as well, beyond just staging. And for this, the subtype A-stage inference model, or SUSTAIN, came to life, which has become quite popular, applied to many different imaging techniques. The original from Young et al. Was on MRI. And basically what the model does is using cross-sectional data and then using that information to put people in subtypes and in stages. So for each individual, you get information on if they are in a different subtype and also where in that trajectory where they are. So here you can see heterogeneous, you need a large data set. They actually have variability in your data to find, of course, these different patterns. So this was the original work where basically for Alzheimer's, using structure MRI, they identified 3 subtypes. And in the colors, you can appreciate which stage, which regions become abnormal first in each subtype. So it was atrophy. Then Jacob Vogel applied this to tau PET, identified 4 subtypes of tau related to different cognitive decline profiles. And then, yes, risk cognitive decline. And then I came and I applied to amyloid. It's like, okay, we start with atrophy, we go tau, now we go amyloid. Every time we go one step back in the disease trajectory. And by using 3,000 or about 3,000 amyloid PET scans of 6 cohorts, I put it into SUSTAIN and just asked, what is the optimal model? Give me how many subtypes there are. So I didn't tell the model how many to give me. And the optimal fit was 3. A frontal subtype with initial uptake in the orbital frontal region, which we know is a classic region. The parietal subtype with a regional uptake in the precuneus, which you also know is a classic region. And lo and behold, the occipital one. An occipital subtype came out, something I've seen on the scans, but no one really ever talked about. Occipitals ignored the visual reads, ignored the centiloid mask. And now it's a subtype, well, quite a prevalent one even at that, to be honest. When the first results came out, I almost yelled in the office, like, it's there, not just my visual assessments. But is there utility to these three? I mean, for tau, for atrophy, we know it's been linked to cognition. For amyloid, it's never been the case. So yeah, who cares, basically? We recently validated these subtypes in a different data set with a completely different approach. We find 3 very similar patterns. You can see the shared by my student in Amsterdam. And together with, oh, sorry, this one first, I want to show the example case of his method. So for example, on the top is someone has a dispersion very high on frontal and parietal, but low on occipital. So you can see a lot of frontal uptake at parietal, but nothing occipital. Well, this is the other one is a case of high dispersion on occipital loading and frontal, but not so much on parietal. So you can see here and here. So with a very different method, with completely different data sets, we basically found the same subtypes. And based on my work, his work, and also others in the literature, I don't have the figure, but I also saw these subtypes be identified by the group in the States. They also found an occipital one. What we've seen so far is that the frontal subtype seems to be more often E4 carriers, a more classic AD profile. The parietal subtype, we see more often early onset Alzheimer's disease. And the occipital one, which now is getting a lot of attention, we see more often dementia patients in a sub-analysis by my own work, DLB, although it was a small sub-analysis, so we need to be careful there. Faster cognitive decline and association with vascular pathology. And that is something that I think a lot of people have become interested in. It's been shown by the States. It's been shown by work by my colleague Luigi, where basically we found 2 patterns. If you have more amyloid pathology in the back of the brain, you also have more vitamin hypertensities in the back of the brain. And also my colleague Leo showed that if you have higher loadings in parietal or occipital, particularly in those regions, you also have more white matter hypertensities. While if you have more frontal amyloid, you actually have a lower chance of having posterior white matter hyperintensities. And there's also been big groups in others that have shown this association. What was really new was last summer, when Lilly all of a sudden came with a very interesting result from their donanemab trial. They looked into if a patient had relatively lower or higher occipital burden compared to the rest of the brain. So not if it's present or not, just it was a ratio measure. But what they showed is that if you have occipital burden, you also had a higher chance of ARIA, the common side effect of anti-amyloid drugs. And what's interesting, and I don't have the official figure, this was my screenshot during the conference, is that this risk associated with more occipital amyloid was even on top of your E4 status. And for those that may be less familiar in the field, if you are an E4 carrier, your chance of ARIA is really increased a lot. So the fact that we see an effect of occipital amyloid on top of E4 status on your chance of getting side effects of these drugs really shows, of course, that something is going on there. The general estimation is that it might be CAA related, cerebral amyloid angiopathy, but the literature is quite debated still on that. And actually, I'm in the process of hiring a postdoc to really look into the utility of occipital amyloid PET. All right, so I've shown you the value of extent. You could use that for risk stratification. I've shown you the presence of subtypes that might have clinical utility, particularly occipital amyloid burden. And now something very novel that I really just started working on 2 months ago myself. And but something I've seen in scans a lot as well. And I just want to share you a bit of the tip of the veil of the stuff that we're doing. And it was inspired by my colleague, Thomas, when I was in the BioFounder group. So we worked on this together. I was a reader for his study, where he looked into asymmetry between left and right hemispheres in tau. So he looked at tau PET. And more importantly, he looked into temporal tau. So not the whole hemisphere, temporal, because it's of course the key region in tau PET, even though we also know there's subtypes there. So, but let's keep that in mind. And what he basically showed is if you compare one temporal lobe to the other one, that quite a number of people have more tau pathology in one or the other. So asymmetry You can see that on the x-axis, the extent of asymmetry, with positive values indicating right asymmetry, so more tau in the right hemisphere, and negative, more tau in the left hemisphere, relatively. You can see the maps of that. So more tau LA, symmetric, more tau RA. And what's really interesting is that the tau asymmetry that he observed was for more than 60% explained by asymmetry in amyloid. And that more direct link between amyloid and tau in terms of spatial organization asymmetry was actually not really shown before. And what was more interesting, and this is where my interest got sparked, when I was reading these scans, is that I noticed, so I was reading a lot of the more asymmetric Amyloid-PET scans, is that asymmetry, if it was really present, it was very often in his atypical regions, temporal and occipital. Much less I saw it in frontal and parietal, or classic regions. So I immediately started wondering, okay, what is the link between asymmetry and subtypes? I'm sure look into this. But he already did so much in his work that we could not include it as well. So that's what I'm doing now. I want to see, is this asymmetry linked to subtypes? Or, even more complex than that. So he also saw that the strongest asymmetry link between amyloid and tau was for the temporal and posterior regions. So I went to amyloid symmetry. I wanted to dive more into this. We took 2 cohorts, Amyloid-PET, I mentioned before. By the way, it's open access on ADA Workbench. If anyone's interested in using this data, it's there for you guys to use. It's around 1,200 non-dependent individuals. Majority is cognitively unimpaired, so CDR0. And we took the A4 study, also available for everyone nowadays, by the way. About 1,800 individuals, all CDR0. And while with tau, they looked at temporal, we looked at the whole hemisphere. So we took the whole hemisphere because we know that amyloid, of course, can be in the whole brain. Cortex, though, not so cortical. And what did we see? Well, if we apply the same method as Thomas did to our Amyloid-PET data, we also can identify clearly individuals with right asymmetry and with left asymmetry in their amyloid. These are the numbers. How many are in either group? It is quite a prevalent thing, actually, in the amyloid world. A few examples how these cases look. So here we have an example of a symmetric case, very positive, 56 centiloid, so higher up in the spectrum. And asymmetry index is basically around 0. And you can appreciate that there's uptake throughout the brain, very similar between left and right. Here we have an example of a left asymmetric case, also very positive, centiloid of almost 80. But the left hemisphere, think of everything, of course, is always switched in imaging, particularly in the frontal, but also a lot more in the temporal lobe. There it is again, temporal. It's higher uptake in the left hemisphere compared to the right. And finally, a right asymmetric, 58 centiloid. In this case, particularly frontal, actually was more in the right hemisphere than the left. I've read about 100 scans now, blinded. I had no idea if there was symmetric left or right asymmetric. I've done it for the more positive cases, but also the ones in that gray zone, so the more tricky ones. And now that we're looking more proper, you can really see it. I scored most of them correctly according to the quantitative status. So that was also cool for me, but so it's really prevalent. You can really detect this just visually as well. For A4, very similar situation. We find it, it's prevalent. Interesting thing though is that for whatever reason, right asymmetry is more prevalent in A4 compared to Amyloid-PET. Why? I don't know. I literally got these results 2 weeks ago, so I'm going to look into it, what that could be. But it's there, that's for sure. And if you compare some basic demographics, so A4 is a much larger cohort, so we have more statistical power. There we see that, interestingly, A beta in centiloid though, but A beta burden is the highest in right asymmetry. Although not statistically significant, we see a similar pattern for Amyloid-PET, so there might be a relationship there. Age, we see that right asymmetry is slightly older compared to the symmetric group. Again, not something statistically significant. Actually, no, I'll ignore that. It's not the case in Amyloid. And ApoE4 carrier is lower in the left asymmetric cases. Again, this is very hot off the press. I need to look into this way more. But yeah, I think it's going to be a quite interesting piece of work that we're going to look into. And we have many next steps planned for this work. One of the key ones, I think, is methodological validation. So there's a lot of debate always with asymmetry. Yeah, to what extent is it not just a tracer getting into the brain well? Is a blood flow issue? We're looking at elderly individuals. We have actually dynamic PET scans in this consortium. So we really want to investigate if the flow of the tracer can explain this asymmetry or not. We also have ASL MRI. So ASL is also an MR-based measure of flow. So we can also correct for that. It's an independent measure. And we want to look at then the stability of change of this measure over time in both tracers. And then once we've done all that, we go to clinical utility. So we're going to relate to demographic and risk factors, polygenic pathway, we have GWAS in a lot of these subjects, changes in brain connectivity, do we see a link there? And again, see if we can find this link with vascular pathology. So with that, I'd like to summarize my main take-home messages for you guys regarding extent, spatial distribution, and asymmetry. Quantification can support visual read, and the Centloid provides a standardized measure to do this. In case of discordance between those two measures, please be aware of quality of the image, lesions that can affect the quantification, and focal uptake that can either affect the visual read or the quantification. The assessment and extent of extent and regional A-beta burden can be used for risk stratification, particularly to investigate if someone has high risk for tau, but also potentially the risk of side effects of drugs. And spatial information could be associated with ancillary disease processes like vascular pathology in particular. And finally, amyloid asymmetry, very ignored in the field so far, but it is prevalent. It's related to tau asymmetry, and who knows what kind of utility there's still in this measure. So I hope to give you much more on that in the upcoming time. In that, thank you so much for your attention, and if there are any questions, I'm happy to take them.
Thank you so much, Lyduine. See if we have questions from the audience. There's one right next to you.
Okay, very nice talk. We were discussing during lunch.
Yeah.
I mentioned to you a case that I have with very asymmetric. It was a logopenic aphasia, and at that time we didn't have tau PET, but the amyloid PET was very asymmetric, even much more extreme than the cases that you showed.
Yeah.
It was amazing. You only have amyloid in the left side, and the FDG PET was concordant, of course. So I wanted to ask you about the clinical correlation. Do you have any idea about clinical correlation of these asymmetric cases? Can you find something that for us clinician can be helpful in that sense?
Yeah. So the cohorts that I included here, we have this asymmetry. They're mostly cognitively unimpaired and more classic AD. So there's not the atypical phenotypes in there. There has been work, that has been shown by also Coppola, for example, that tau PET is very related to the clinic, while amyloid PET is not. So there's no evidence for that yet, but I would say, we're now moving earlier and earlier. And maybe if you're looking at an earlier stage where tau is less a driver or less prevalent of the clinical impairments, maybe amyloid actually is maybe a more important driver. So at this moment, you can't use it, spatial information, for differential diagnosis or clinical phenotypes. But maybe if we move earlier, where it might be more of a driver disease, who knows? At the moment, no, don't.
Yeah, I have a question related to the prevalence
Yeah.
of this asymmetry in amyloid. And obviously, prevalence depends on how you define asymmetry. And I noticed that you had like a symmetry index threshold of 5 or 6, or I don't know, which looked different to the ones used by your colleague for the tau PET study, which was, I think it was 10. I don't know how this index is exactly defined, but so do you think it's the prevalence when using the same defining criteria, meaning threshold on this particular index, is similar between amyloid-PET and tau-PET? Because one would assume, or the general opinion in the field, is that it's much more common in tau-PET than amyloid. That's why I'm asking.
Yeah. Now, so the approach that we took to determine amyloid symmetry is the same as that Thomas did for tau. So we use the same, like 1SD using the curve and applying that. He had a few additional conservative measures, though. That is something we want to apply to be more conservative. And that's why we also really want to do the methodological validation to make sure it's not due to, you know, noise, flow, and these sort of things. But yeah, these things always fall with your definition. But in this case, we applied the same main approach as he did. So maybe it isn't more prevalent than initially thought. The main thing is, though, it's not as extreme, I think, as tau. I think that's the main difference. So the number of individuals that fall within the category of being asymmetric, that's there. But the extremeness is less the case, I feel.
Yeah, that's actually one of my follow-up questions, whether, because the examples you showed fit totally in this idea, because they were all like quite advanced amyloid cases.
Yeah.
So I wonder whether the reasons for this asymmetry may be different. Well, first of all, if you see this asymmetry also in early accumulation, so and if yes, maybe the reasons may be different, right? Because in a very advanced case, you may think of maybe there's just too much atrophy there. So if there's no cortex left, you can't accumulate, right?
Yeah. I think so. The advanced cases here maybe are less applicable because they're all cognitively unimpaired, or at least the majority are. And it was not the case that the ones that had the most extreme asymmetry had the CDR-half and Amyloid-PET. So in terms of atrophy, this should be quite fine. I did also look at, I didn't have the examples, but I did also look into gray zone individuals who really have emerging pathology. And there you see it too. We all have the same values as well. I can go back to the plot. You also saw more extreme of those that are just around the 30 cutoff, basically. It's less the case for sure. So the asymmetry becomes more extensive as you have more amyloid, which makes sense. But it's also, you can also observe it still in the earlier stage of the Alzheimer's, of the amyloid pathology. Yeah.
Thank you. Thank you for your very interesting talk. I'm not familiar with the amyloid-PET pathology, but I would like to know if the amyloid-PET capture all the amyloid pathology in the tissue, or because this spatial difference you had discrepancy maybe is related to to that, or how at the molecular level or configuration level of the fibrils, you know, you capture everything, or we are missing something?
Yes, we are. Thanks for that question. It's a very important point. So most of the signal we see from amyloid-PET is neuritic plaques, or really end-stage plaques. PIB and flutamidamol also bind quite okay to diffuse plaques, but 1/4 of the signal less though. So that's why we can use those traces also for the deep gray structures, like in striatum, for example. You're allowed to look at those regions, while for beta-Ben and for beta-Pir, you're not. There is some, I had a very long discussion with our pathologist or from GE that I work with a lot on what is a bit occipital, what is there that it might bind to? Is it a different amyloid-PET configuration, you know, the type? He said, no, it's not actually a lot of neuritic plaques there, but maybe, you know, it's a CAA it binds to that gets stuck in that as well in the vessels. So the honest answer, that part we just don't know. I'm actually going to collaborate with GE, go back to their postmortem data to have a better look so we can answer that question. But in general, yes, we're missing a lot of the different forms of amyloid accumulation and plaques with these tracers. It's more end stage, but flutamidamol and PIB at least diffuse plaques to a certain extent. So yeah, but more to be, yes. Yes. That's why I need hands.
Do you correlate this with ligands for neuroinflammation, you know?
Yeah, oh, I wish I could. So in the data sets we have currently available, we don't have yet ligands of neuroinflammation, but I know in the BBRC, the alpha cohort is starting with that. And we have alpha in here. They're amyloid-PET scans, so hopefully in the future or sort of collaborations, because the AMI-PET consortium I mentioned, we're now called EuroPET. So we keep growing and we're keeping more family members, almost I want to say, coming in with their data. So hopefully in the future, it's one of the aspects that would be really interesting to look at as well. Yeah.
Okay, thank you.
My question is perhaps too speculative. I apologize. But have you ever considered that this difference in pattern of symmetry could be related to different physiopathology or even etiology?
And such as which ones?
If this difference that you have presented could be related to different physiopathology or even different etiology.
So I think, well, the main one that I've considered and want to exclude is the lack of blood flow of the tracer actually reaching the brain. So that there's vascular pathology, so that the tracer can't get to that cortex well, and therefore there's a lower signal compared to the other one. So with the dynamic PET scans I have and the ASL MRI, which measures blood flow in two different ways, I hope to exclude at least that potential explanation. But if you have other suggestions, I would love to hear.
So this sounds more now like a technical explanation for this difference, but then you also mentioned the potential relation to vascular pathology. And in that context, it may actually have the same effect on the perfusion. Maybe if it is related to, in some way, to vascular pathology, the same vascular pathology may also affect the perfusion.
Well, the vascular pathology has been shown now is more the microvascular one, so the white matter hyperintensities, and that should not affect at least the large arteries to the extent that the tracer should not get into the brain. But still, that's why with the dynamic scans, we're getting actually binding potential, we take that into account. So I want to see, first of all, do we see asymmetry with binding potential, which is an actual measure of binding and not a derivative like SUVR. And then on top of that, we can look at the flow maps using R1 and ASL. So it's sort of combined, but microvascular damage should not affect that too much, because otherwise amyloid-PET is void by default in most older individuals, I would say. If you think,
Yeah, and the related question is about CAA. You also already mentioned it. Or let's say more about the occipital subtype in general, because this seems to be, for now, since you don't have much data on clinical data on these asymmetric cases, for now, this seems to be like the most clinically the most relevant subtype of distribution differences. So do you have data on white matter hyperintensities or some standard vascular pathology marker on these individuals?
Yeah, so we collaborate a lot with Carol Sudra from UCL, King's now, I should say. So she has developed a very nice segmentation tools for white matter hyperintensities. So we get total loads, but also per lobe. So that's something we already have. And she's currently working on CAA as well, segmentation. But next to that, we just have extensive visual read assessments by our radiologists. We're actually expanding the data set in AMI-PET. So we have it for a few of the cohorts and want to expand it. So yeah, we have quite a lot of this data available to look into, luckily. So I'm hoping to answer that maybe in a few months' time.
Right. Related to that, microhemorrhage, have you checked microbleeding?
The micro, so the CA is the microbleeding in the cortex. We also have regional information there. So for some of the cohorts, we only have total number and whether it's cortical or not. So we want to dive more into that. We also have lobar information. So the EPET cohort, which is like the mother cohort of AMI-PET, has it extremely detailed. And so we make it a bit less detailed because there's a lot of work, but we will model everything else to that. So you'll have cortical microbleeds and deep microbleeds and per lobe. So that's the main data that we'll look into.
Thank you very much for the presentation. It was really interesting. I would like to ask you about the image that you show about the subtypes based on the pattern. In none of them have or has like amyloid in the motor areas, precentral or postcentral. And I would like to ask you if this is because of the radio tracers or it's just because the pathology is not there?
Yeah, so pathology has been shown in this region in really end stage. Same as with cerebellum. At one point it shows up, but extremely late in the disease course. So usually these individuals are not included in our in vivo studies. I have to say, knowing how this region is a bit messy, it can give noise. Same for very small regions from the atlas. Think of the bank SSTX or pedicalcaline. They tend to misbehave a little bit. So for all the staging and data-driven analysis, we actually remove these regions from the analysis. That's why they're missing in the figures. But also they don't show, these two particular don't show anything until really end stage disease. Yeah.
Thank you.
Hi, Lyduine. Thank you so much for your presentation. I found the part about amyloid asymmetry really intriguing. And I don't know if it's too soon to ask you this, because I think you don't have any maybe data on this, but I'm going to ask it just in case. What about co-pathologies?
Yeah.
There may be interaction, and whether maybe this amyloid asymmetry is more indicative of the interaction between co-pathologies and not only the biology of amyloid pathology.
Yeah.
Could that be the case, for example? Have you thought about that?
Yes, that is my expectation, I would say. I don't know the asymmetry. I find it difficult. The asymmetry, I'm not so sure if that's co-pathology, because I mean, Weidman hypertensies tend to be usually frontal or parietal, but in both hemispheres. So that one. Same goes for alpha-synuclein. Also doesn't tend to be very, one hemisphere more than the other, I believe, at least when it reaches the cortex, I should say. So that one I don't know, but the interaction maybe between asymmetry and the spatial. So the fact having a more in the posterior part of the brain and then maybe occipital on one side starting before the other one. I think that is really where the co-pathology interaction comes in with the vascular, but also potentially with the DLB. I mean, I saw in a small postdoc analysis of my subtype work that the occipital was more common in DLB individuals. We now see in Alzheimer's individuals have RT-QuIC positive, they have more posterior FTG being lower. Well, there's also debated there. So I think that spatial information in itself, together with these other markers, will be very important to understand the interactions there. Yeah, I don't think it's just Alzheimer's, indeed. I think something else is driving these patterns that can give us information on someone's disease course. So I would like to understand it, but also subsequently use it for risk stratification, maybe optimal treatment when we have multiple options. These sort of things. Yeah.
Right. Thank you very much.
Yeah.
Okay. Just follow-up commentary maybe to that. You say that Lewy body pathology does not tend to be asymmetric.
In the cortex, right? Or...
Yeah, so I'm not a neuropathologist. I'm just saying that the same, probably the pathologic literature says the same about amyloid and tau and virtually all pathologies, because they're rarely assessed symmetric in both hemispheres, and the same for the pre and post central cortex, because the same would hold true for the occipital cortex. Yeah. And so I think we have to be careful when in our neuroimaging data doing like referencing the neuropath literature, because we are limited in our ability. We have much more. We have to deal with like artifacts, and we have to interpret our signal right. And well, in contrast to neuropathology, who, well, if they see the pathology, it's there. But we have a much higher regional sampling rate, and this should not be underestimated, this advantage in neuroimaging. No. And so we see, in the spatial sense, we see a lot more than most pathologic studies.
No, so, thanks. I really appreciate that comment. It's a very good one. And also think of, the in vivo biomarkers that we have that are proxies of alpha-synuclein with dot scanning, and so they all show asymmetry, at least in the initial stages. So it's probably more asymmetric as well. Thanks.
Okay, if there are no other questions, then thank you again, Lyduine.
Thank you for the invite. Very much appreciated.